Hello, my name is Dr. Fors Gazazi. I'm a doctor working in the NHS. Today we're going to cover my crash course in embryology for medical students, Embryology Made Easy. This course is the culmination of 5 years' work. I've been delivering this course every year to medical students at several universities, and it's generally well received. The purpose of the course isn't to go into the nitty-gritty of all of the embryology that you're taught for your medical degree, but rather to give a general overview and highlight the key examinable points and also the key clinical points of the embryology that you're covering during your degree. We'll divide it into three parts, three separate videos. So the first part will be on fertilization, implantation, and gastrulation. The second part will be on folding, segmentation, and neurulation. And the third part will be on organogenesis, covering the whole organ system formation. So without further ado, we'll get started. To understand embryology, you have to understand that the core concept underlying the whole science is that it's the change from an undifferentiated cell to an organized multicellular structure. And to be able to understand some of the processes that we're going to discuss and the migration of cells and the development of complex structures, you have to appreciate these four processes. The first is obvious, it's differentiation. It's a process of development where an embryonic cell specializes and from that diverse tissue structures arise. The second is division and multiplication, and there's a subtle difference between the two that's often assessed in exams. But effectively, division is a process of equal separation, i.e. the cytoplasm is shared between two future cells, as is the nuclear material. And then multiplication is the process of identical duplication. So in this case, everything is doubled prior to the division. Now, chemotaxis is a key chemical process that's used throughout the body for all sorts of things, such as vasculogenesis. It's part of our immune response. And also as part of the primary hemostatic response as well. And this is the chemical attraction of cells. It leads to movement because there is a gradient to which the cells are attracted. And so this is where a key embryological molecule, morphogens, really come into their own. And effectively, morphogens are molecules that exist along a gradient and often an opposing gradient as well. And cells possess the ability to detect the concentration of morphogen in the surrounding area, such that the concentration of morphogen will lead to differentiation of the cell, will lead to migration of the cell, will lead to stimulation and buildup of actin myosin. It's a really impressive microcellular process that occurs. But in this case, the morphogens create a gradient which leads to the attraction of the cells down that gradient. And that's with this actin myosin propelling. So there are lots of different ways that actin myosin at a microcellular level can lead to cellular movement. One way is, as we'll discuss on the next slide, is convergent extension. The other is that you can actually form these really impressive looking actin rocket type cells where the actin builds up at the back and as a result propels the cell forward. Now, convergent extension is a very key process in embryology, and this is the shortening in one plane and lengthening in another. And there are several ways that it can occur. The first way is with a single layered epithelial surface of cells, and here individual cells are shortening and lengthening. An alternative is with intercalation. Here we see, two layers of cells at least that mix together such that they form an interconnected layer of cells. And the final is convergent extension. And here you see the layers of cells migrating and converging onto a point and then coming out of that point with less layers than they went in with. So they're the key cell processes. So now we'll discuss what happens in the early stages of embryogenesis, and the structures that we're going to discuss here that I'm sure you've come across before: the oocyte, the morula meaning, I believe, Latin for mulberry, blastula. The blastocele is the blastula but once a cavity is formed, hence the name cele. And then the blastophore is when this cavity almost forms a sinus of sorts. You can call it a blastopore. And then trilaminar disc, This is the three-layered structure that underpins a lot of embryology and what some embryologists would consider to be the key process that occurs in the whole of embryology. And so if you're doing, vivas and things like that, sometimes people ask what the critical process in embryology is, and that's a good place to start. And a lot of this has been known for absolutely centuries. If you invert a chicken egg, it creates an air bubble at the top. And a fertilized chicken egg, you can take the top layer of shell off at various stages post-fertilization, and you can observe the embryo forming on the membrane sitting beneath that air bubble. And it's something that Aristotle did until the third week of chicken embryo formation. Now, this is a rough timeline for fertilization to implantation, and I think often students ask me what happens on day X, what happens on day Y, and this is where this concept of Carnegie stages is really, really appropriate. And effectively, Carnegie mapped out the 23 stages of the first trimester such that the variation in days didn't really matter, because you could chronologically define the 23 stages. And so sometimes it's easier to think of things in the order in which they happen rather than the days, and that's firmly what's going to be the mechanism by which this course is run, as it will discuss things in chronological order such that you see why the following process happened. But we'll discuss fertilization, we'll discuss cleavage, particularly in the context here, why there's a subtle difference again between the multiplication and division, and then we'll also discuss implantation and early formation of the placenta. So a key fact often assessed in exams is, where does fertilization happen? Typically, fertilization occurs in the ampulla of the oviduct. And that process of fertilization is very interesting. Where often there's that adage that the fastest sperm is the one to fertilize the egg, the best sperm, the quickest sperm, the most energetic sperm. But actually, breaking down the oocyte's glycoprotein shell is an enzymatic process. And so the first sperm to arrive will contribute to the breaking down of that glycoprotein layer, but may not necessarily be the ones that fertilize the egg. So these can be described as kamikaze sperm. They come in, and then a few sperm down the line, one acrosomal reaction occurs that is critical to breaking and penetrating that glycoprotein layer, and that sperm will end up fertilizing the cell. And what's really important here is that once that process occurs, there's a cleavage of these zona pellucida 3 receptors, and that prevents a duplication of nuclear material inside the now fertilized oocyte. If you imagine that once you had one sperm fertilizing it, you no longer wish for other sperm to be able to do that. And so the binding of the sperm to the oocyte actually is very important for the embryological processes that follow, because at the binding point there is a series of calcium fluxes that dictate future cleavage points. And this can be reproduced experimentally by ectopically placing a sperm head to dictate the point of fertilization and entry, and then radio labeling the calcium molecules to see this flux and wave that is generated from the entry point. Now, a key examinable fact that you'll often see in MCQs, for example, is whether the order of meiosis and mitosis, or the order of meiosis and cleavage. And it's key to remember that meiosis of the gametes happens prior to the cleavage of the fertilized oocyte. And logically, this makes perfect sense that you would want to combine and create the heterogeneous chromosomal material prior to cleaving the cell, because cleaving and then leading to meiosis, there would be no guarantee that the combination that occurs in the two the two cleaved cells would be identical. I mean, when I say there's no guarantee, it's near impossible. So to continue the propagation of identical genetic material, the meiosis clearly has to happen prior to the cleavage. Now, this is a diagram demonstrating these processes that we've just discussed. Here is the sperm making contact. It'll bind using these ZP3 receptors. This is the acrosomal reaction, a breakdown of the cell membranes, allows entry of the sperm nuclei, and then allows fertilization. Now, this calcium flux that we described earlier, as I said, that will lead to that will dictate the plane of cleavage of the fertilized oocyte. This process is actually, when compared to amphibians and birds, much slower. But the key for your exams is that there is subdivision of the zygote without a change in size. Okay, so it's not that there is a multiplication process, there's no increase in the cytoplasm, but this now fertilized oocyte, the zygote, is going to divide without a change in size. And it divides into a series of blastomeres. Each cellular component will be described as a blastomere. And so you have this 8-cell blastomere, and it has a loose arrangement such that each cell has equivalent contacts. And then what you need to do is this structure then needs to develop some polarity so that you can differentiate different aspects of the blastocyst. So there is a division to a 16-cell morula. Okay, and in that division, if you imagine that now by being 16 cells, there are cells on the outside and there are cells on the inside. So the cells on the inside have no contact with the external environment. Okay, whereas the cells on the outside are contacting other cells on at least 3 of 4 sides, if we imagine that they're squares, but on the outside surface have no contact with cells. Okay, so what that means is that you now have an inside-out polarity, such that the inside cells, like I say, are surrounded by other cells, are surrounded by these cell-to-cell stimuli, cell-to-cell receptor interactions and propagation of secondary messenger systems, and the cells on the outside are receiving less of that stimulus because they have a surface which isn't in contact with other cells. And in order to keep this structure maintained, you have the cells adhere to each other using this molecule E-cadherin, epithelial cadherin, and this is a homodimeric reaction such that E-cadherin only binds with other E-cadherin molecules. And it's a strong connection, and it allows it to compact and stabilize to form this sphere. And as a result of that inside-out polarity, what you then dictate is the formation of the inner cell mass, which will form our embryo proper, and the trophoblast. Now, it also allows for differential expression of these active sodium-potassium pumps that will pump sodium and potassium ions into the structure, and then following that along the osmotic gradient, there will be fluid, and that will create a cavity such that our blastocyst becomes our blastocele. Okay, and then as you'll see in the next diagram, this will actually put the ICM on one side of the blastocele, and it will put the trophoblast all around. But effectively, you have one side that has inner cell mass that's going to form our embryo proper. This is our embryoblast, and one side where there really isn't any structure that's going to form our embryo, and that's why you can describe it as having an embryonic and an anembryonic pole. The embryonic pole being here, and the anembryonic pole being there. Now, the ICM is pluripotent, and at this point, the cells can be taken to form embryonic stem cells. The trophoblast will form 2 distinct types of trophoblast, the syncytio and the cyto. So much like in cardiac physiology, the syncytium is the loss of cell membranes. So you'll have multiple nuclei for one collection of cell cytoplasm. Okay, so there'll be several nuclei contained by one cell membrane, compared to the cytotrophoblast, where it's one nuclei per cell membrane per collection of cytoplasm. And the importance of the distinction we'll discuss shortly. The inner cell mass is bilaminar, so it's got two layers, and they are the epiblast and the hypoblast. This is often assessed because it comes down to the nitty-gritty of the nomenclature in embryology, and I often see this in the MCQs because they like to differentiate between candidates. And so there are two types of endoderm, and we'll discuss it more in gastrulation, but there's the primitive endoderm and the definitive endoderm. And this comes from the fact that the hypoblast is extra embryonic, i.e. will not form part of the embryo, but you also have a primitive or an extra embryonic mesoderm, and structures that are likable to an extra embryonic ectoderm. But this is called the primitive endoderm because it's later displaced by the definitive endoderm during gastrulation, as we're going to discuss shortly. But in this inner cell mass having two layers, it now has another set of polarity, and it creates the first axis of polarity in the embryo proper, and that's the dorsoventral axis. Okay, so by virtue of there being two layers, there's obviously asymmetry in one plane, and that creates this dorsoventral axis. And ventrally, you have the epiblast, and dorsally, you have the hypoblast. Now, the hypoblast will end up forming the yolk sac, and that will determine the orientation of gastrulation, as we'll shortly discuss. Now, we need to form the amnion here. And it was initially thought that there was a ball of epiblastic cells here, and some of them will apoptose and disappear. But actually, the process doesn't involve apoptosis. There's this asymmetry of the actomyosin bundles at the top here, and they contract, and this contraction leads to a gap. And this gap becomes an amnion, and this is often called the purse string model, or like a belt around a set of shorts, for example. Imagine you pull both sides of the purse string, and everything that was in a nice layer comes round together and leaves a hole in the middle. And if we take a step back and think really about, why all of this is necessary, and when you compare mammals to, other egg-laying animals such as reptiles and birds, they obviously don't have a need for a placenta, but that's because through the egg that they lay, oviductal nourishment is significant enough to carry that fetus to term. And to what is the equivalent of birth. But in mammals that's insufficient, and so a hemotrophic method of exchange is required. So take a step back and think about the timeline. So around day 3 to 4, this morula reaches the uterus. We have an equivalent stage of hatching, I suppose, as it breaks through the zona pellucida in order to be able to bind to the endometrium and start the process of implantation. And then between day 6 and 7, the trophoblast cells at the embryonic pole are going to form the syncytio trophoblast that we mentioned earlier. And so now that it's broken through the glycoprotein layer, it's got this syncytio trophoblast that's ready to implant. It binds to the endometrium of the uterus, and the syncytio trophoblast invades the cells. And I think, again, it's often asked, is a syncytio trophoblast, a cytotrophoblast, which is responsible for implantation? And the way to remember that it's the syncytio trophoblast is because you want that loose cell structure for it to invade, much like a liquid, to break through the cellular connections of the endometrium and invade it ready to form a placenta. If it was a cytotrophoblast that was doing it, you would need intercalation of cells, as we saw earlier. It would be a much more difficult process for the trophoblast to leach into the endometrium to form the connections. So the syncytio trophoblast, by virtue of being syncytium, with looser connection, looser cytoplasm, can invade this endometrium, and then with the maternal capillaries form these sinusoids that will rapidly anastomose and effectively be the primitive vasculature of the placenta. But obviously that's going to be insufficient going forward, because you need good exchange of blood to be able to remove toxins and introduce oxyhemoglobin to the fetus. So as this anastomosis develops between the two systems, the cytotrophoblast, which has that cell structure that we crave, will then actually go into these sinusoids and form the primary chorionic stem villi. So it provides structure to these maternal sinusoids that looks more like a vasculature system, that has more interconnections, more stability, and more ability to transfer nutrients. Okay? And the key clinical process here is that this implantation of the trophoblast leads to upregulation and expression of beta-HCG, which is beta human chorionic gonadotropin. And that's used clinically. It is actually very significant clinically, because that forms the basis of urine pregnancy tests. But also by monitoring, doing serial measurements of the serum level of beta-HCG, it allows a clinician to understand whether a pregnancy is viable or is an ectopic pregnancy, as we'll shortly discuss. Because you would expect to see doubling of the beta-HCG level in every 24 to 48 hours in a viable pregnancy, to correlate with the development of the placenta. And the implantation and creation of a mature placenta. But this concept of ectopic pregnancy is very, very key to a lot of clinical medicine. It's something that's emphasized in accident and emergencies and in surgery and medicine. But effectively, clinicians are reminded to consider any woman of childbearing age to be pregnant until proven otherwise. And this dictum comes from the idea that although we trust our patients, and there's a good clinician-patient relationship, missing something as key as an ectopic pregnancy really is quite tragic and can quickly develop into a very life-threatening disease. So any woman that comes into accident emergency is offered a pregnancy test, and then if they're presenting with abdominal pain, as it's a key part of the differential, they must have a pregnancy test to rule out an ectopic pregnancy. And what that is it's implantation of the fertilized egg, the zygote. It's implantation of this structure within the fallopian tube, i.e. at an ectopic site. And the way I always think about this is that if you imagine that the body is a process of laminar flows, okay, so, much like in the cardiovascular system where there is turbulent flow, you get murmurs and you get the formation of thrombi, and the formation of, plaques and plaque ruptures. As the egg moves through the fallopian tube, that is typically a laminar process, okay? There's very limited restriction and turbulence. But then in patients that have had, for example, previous operations leading to scarring, previous infections that have led to pelvic inflammatory disease, for example, or maybe they've had a previous operation on their fallopian tube to remove an ectopic, to remove a lesion. All of these inflammatory processes lead to scarring or a change in the tissue texture at the site of that previous inflammation. And what happens is that the egg, the oocyte, is more likely to implant at this site of inflammation in the fallopian tube. And then as it implants there, it continues to grow, it will divide, it becomes multicellular, but obviously it's constrained by the physical dimensions of the fallopian tube. And so eventually it reaches a critical point where the fertilized oocyte, the blastula, continues to divide, but outgrows the fallopian tube. But then that can lead to a rupture of the fallopian tube if it reaches that stage. And often, description of pains in the, pain in the body, particularly, visceral pain. The pain that someone feels, with kidney stones, with gallstones, with inflammation, isn't necessarily the inflammatory process, but is actually the pressure or the pressure of something, in this case, within a tube. So the pressure of this dividing structure within the fallopian tube will lead to the initial pain before the inflammation will disrupt and irritate the abdominal lining, leading to the abdominal cavity lining, leading to more pain. But inevitably, if it's not caught early enough, it will rupture because it'll continue to grow and burst through the fallopian tube. And if you have a patient that you're suspecting an ectopic pregnancy in, you should always be more concerned if they mention that, associated with this really bad abdominal pain that they've got, that they also have pain in the shoulder tip. And that's because the free fluid in the abdominal cavity irritates the underlining of the diaphragm. As I'm sure you've probably heard lots of different ways to remember innervations and dermatomes and everything, but C345 keeps the diaphragm alive, and C345 of the dermatomes is that upper deltoid to shoulder tip area. And so irritations of the phrenic nerve, the sensory aspects, I should say, really, the pain is referred to the shoulder tip. So that's ectopic pregnancies, a key thing to understand and way that the embryology correlates clinically. And then we'll move on to gastrulation now. And so gastrulation is the process of forming this trilaminar disc from this bilaminar inner cell mass. And a key consequence of gastrulation, and one of the reasons why it's so important, isn't just formation of the germ layers, but it's actually because at the end of the process of gastrulation, the body axes have been defined. All three body axes. You have an anterior-posterior, a craniocaudal, and also a left-right axis. And issues with the definition of these body axes leads to very severe consequences in the offspring. But the process of gastrulation is marked by the formation of the primitive streak, and this is this midline dorsal structure that you can see forming on the bilaminar disc. A primitive node can be seen at the cranial end. Okay, so again, starting to demonstrate that asymmetry that we're seeing as a result of gastrulation. And then the epiblast cells of our bilaminar inner cell mass will ingress into the primitive streak. So they'll come into the primitive streak and then migrate away from where they came. Okay, and then to do this, imagine it's quite difficult for epithelial cells. It's a very rigid structure, strong connections between cells. They're layered. To suddenly be able to ingress somewhere and then move away. And so the way this does is a very key process in embryology is the ability for epithelial cells to transition to a mesenchymal state and then to be able to return to an epithelial state for more structure. But so they undergo this process of EMT, epithelial to mesenchymal transition, as they ingress through the primitive streak. And the first epiblast cells to ingress through the primitive streak will displace our hypoblast. Remember earlier where I said that you've got this primitive endoderm, but you also have the definitive endoderm. So these initial epiblast cells will displace our hypoblast, leaving the definitive endoderm. And then what you have is a layer of a definitive endoderm, and then you have the primitive streak, obviously, and the epiblast. So another layer, another series of epiblast cells will ingress and sandwich between these two, such that you have the new definitive endoderm, the mesoderm now, and then the epiblast, and then finally the final epiblast cells will undergo EMT during gastrulation through the primitive streak and form the ectoderm. And the result of that, there's now a 3-layer structure with dorsoventral, anterior, posterior axes, with the endoderm most anteriorly slash ventrally, and then the ectoderm dorsally. And at the same time, the left-right axes forms, and this is a really clever cellular process whereby there's differential gene expression due to the wafting of molecules to one side and the inhibition of molecules on another side. And without getting into the specific molecular processes of this, effectively there are cilia rotating on these motor proteins, and they rotate clockwise because of this upregulation of these crown molecules at the tip of the cilia that bend them in a certain way, such that they generate clockwise current. And this moves the promoter molecules onto the left and the inhibitor molecules on the right. And if you think, this is such a key process because clinically and physiologically and anatomically, the asymmetry in the body is so important for regular function of the body. And then finally, it can be easy to think that if we go back all the way back to this, that this slide here, that actually the implantation site is going to determine which aspect of this inner cell mass becomes anterior, posterior, dorsal, ventral, and that the process is dictated by the uterus and the endometrium. But actually, it seems to also be underpinned by this lefty one gene expression. And the way you can, show this experimentally is that you can alter, obviously, the levels of expression, but you can ectopically take this key bit of anterior visceral endoderm and place it elsewhere or in different locations along the disc, and then you can see the effect this has on the axis formation and the resultant organogenesis and embryogenic processes. And so that concludes part 1. So in this part, just to summarize, we've discussed fertilization to implantation, we've discussed the formation of the bilaminar disc, the importance of the trophoblast, clinically the consequence of the trophoblast implanting, and the importance of beta HCG and ectopic pregnancies. And then we've concluded by discussing gastrulation, the formation of the trilaminar disc, and the key consequence of gastrulation, which is the 3 axes definitions of the embryo. So I hope you'll join me for part 2, which will be discussing the segmentation, folding, and also neurulation of the trilaminar disc.